Welcome to all. At the outset, I'd like to thank all the people who are going to log into this particular exciting topic of what you choose is Omicron, what causes variations, how to deal with it. To moderate this session, I am Dr. Sudhir Kumar K, lead and senior consultant pulmonologist at Aster CMI Hospital. And to discuss this panel discussion, I have two eminent people who stood the test of time in terms of how to tackle this COVID pandemic at Aster CMI by setting a truly example of leadership in terms of tackling this COVID-19 in the last 2 years. To my right, I have Dr. Prakash Doraiswamy, a senior anesthetist and intensivist at Aster CMI Hospital. And on the left, I have Dr. Srivatsa Lokeshwaran, a consultant intervention pulmonologist at Aster CMI Hospital. Next 25 minutes or 30 minutes or so, what we are trying to plan to is to discuss some of the challenging aspects of Omicron, how to deal with, and what are the take-home messages. Now, to sum it up all this thing, before getting to Omicron, I'm going to run through next 5 minutes how this summary of 2 years we've taken us from the scratch to the area where we are in right now. Probably if you see that literature from December 2019 till now, there are more than 278,000 papers which have been published in the PubMed actually to questioning, unlearning, relearning about the science of how Omicron or COVID, which has prevailed in the last 2 years. Now, to sum it up, I think I'll go to this particular discussion where when we started the origin of COVID, it started in Wuhan, way back in December 2019, where few subset of patients with acute respiratory events get into ICUs, clogged in, where tried all your ARDS measures actually, but with not good amount of success. Then there was a pandemic signals actually where it got into the level where this to seafood market actually, which is nearby Hubei province actually, which is a source of this sort of a coronavirus. Within a span of a month or so, they were able to isolate the gene sequence actually, and they named it as coronavirus. Is it a new coronavirus? No. Already we have seen two more endemic things actually in the past with the SARS-CoV-1 and the MERS, way back in 2002 and 2013 respectively. At the same time, once we got into the mode of how this thing, coronavirus spread, within a span of couple of weeks, there was an exponential explosion of this particular virus invading into multiple continents without much of a therapeutic armamentarium being very strongly advocated actually. Then at March 11, WHO came up with a thing that said it is a pandemic, no, it's an endemic sort of a disease, where the whole world was on alert, and the saga continued for 1.5 to 2 years as of now when it started. When it comes to the outcome, challenging aspect, three challenging aspects which are tested in this whole pandemic is healthcare system, how strong your healthcare system has been built with, the political commitment in terms of how to execute this from a scientific world to a common man, and the governance which what we have built up actually. How this is going to be executing with the proper commitment and inclination towards your committee out of all these things. Now, when it comes to medical fraternity, the virus, we know that it is SARS-CoV-2. Now they started building up the knowledge in terms of epidemiological aspect, how does it spread? Predominantly aerosol and droplets. No doubt it's not something new. As a pulmonologist, we always have this sort of a tuberculosis also in the picture, where we know that it's more of a droplet and a sort of an infection which get transmitted. Now, invariably, they strongly backed upon with your mask, your social distancing of more than 6 feet, and at the same time hand sanitization. These were the tenets of how you were managing this particular thing onto our lower mode of isolation or home quarantine, putting all this thing into a new behavior changes what was noted in this particular COVID. At the same time, till then, nearly 56 lakhs death in the last 2 years. At the same time, in Indian context, actually, nearly according to 8 to 10% of total number of cases, and also 8 to 10% of mortality, which is burdened by Indian context. Now, to sum it up, the Indian three waves, what we call to, where we are right now in the third wave, if you see that the first wave, which was where in the month of July till November, where more than maximum number of cases, what we saw, it was nearly to 1 to 1.2 lakhs. At the same time, mortality were 1 to 1.5 thousand was a mortality. And the most salient features what we can use to draw from the first wave is more of an apprehension. Whether we have geared up to tackle this, the apprehension in terms of medical fraternity, adapting on new norms of personal protective equipment, and also the epidemiological guidance giving a flattening of the curve, where the lockdown was enforced to flatten this curve, as if this is the only one curve which has to be flattened. Now, with this good preparation and all things, somehow we were able to downstream that initial numbers by the end of November. Then we tipped into a second wave. We started from February 2021 to May 2021 with the peak case going up to 4 lakhs per day. And at the same time, mortality was equally matched with 4.5 lakhs, 4.5 thousand deaths per day was what the maximum what has been documented. The most common key points what we can draw from this particular vaccine was rolled out but not adequately covered. Second, the shortage. Everywhere there is a shortage of ICU beds, hospital beds. At the same time, we never thought in the thing that whether we have a pharmaceutical companies getting this sort of a limitation of providing the medication in the right proportion to get the patient out. Now, this also came with a leftward shift, where first wave predominantly we had an elderly population being affected. From the second wave on, we could see that the leftward shift, where the younger patient also got involved in this COVID pandemic, and this lasted for only 3 months. Then, with the robust vaccine strategy covering most of these aspects, with a rapid coverage of this particular vaccination, we went in for a third wave. We started from January this year. I think we're in the peak of our pandemic in third wave, where we are having a data of number of cases going up to 3 to 4 lakhs per day, with mortality of not much compared to the second wave, with around about 600 deaths per day, but still it's also a concern. Now, this curve is predominantly driven with Omicron. Omicron is a variant of concern which was depicted by WHO from 26th of November, where a rapid surge of cases in South Africa prompted us to get into this Omicron, which is known as a variant of concern. Now, to sum it up from the clinical perspective, how the pathogenesis is evolved in the last 2 years, we have this based on clinical signs, symptoms, and treatments, which is depicted by a wonderful diagram which depicts the COVID-19, where we have 3 phases which have been documented. Initial first phase is viremic phase, second phase is more of a pulmonary phase, where the patient presents with shortness of breath, and the third phase is a more hyper-inflammatory stage, where there has been a made headed to a critical care specialist actually to tackle this thing in a comprehensive way. No doubt the presentation, to make these things more precise, we have this presentation of the clinical into a mild, moderate, severe, where the mild somebody with predominantly a respiratory symptom of fever, cough, throat pain, without shortness of breath, and a saturation more than 94% qualifies as called a mild disease. As compared to moderate, where the respiratory rate more than 26 per minute, and at the same time saturation dropping less than 94 but more than 90, with all the respiratory fever, cough, shortness of breath coming in the picture. As compared to the extreme, where severe category, where the patients are too sick, saturation less than 90%, needing a life support, getting into multi-organ involvement with a cytokine storm coming in the picture, we are dealing with the sickest lot. If we compare the percentage-wise, 80 to 85% comes into mild category, as compared to 10 to 12% in the moderate category, and less than 5% in the severe category of this COVID patients. Now, I think this virus is something which came ahead of us actually when it comes to its adaptability to the situation, whatever that comes in our way. Predominantly in September 2020, we had this alpha, beta in October, November we have gamma, and in this month of December 2020, we have this sort of a delta, which has stormed in such a way that the whole of the healthcare system, one of the best, US healthcare system also was brought into the knees. The bottom line is, from the last 10 months, I think we didn't have any major sort of a variants unless until we came up with the November with the Omicron. So the talk in this particular session will be specifically going into the Omicron aspects. Before going to Omicron, I would like to ask my colleague Dr. Shiva Shah to enumerate what is his experience in dealing with mild to moderate cases in the last 2 years.
I would like to thank Dr. Sunil for that overview on COVID-19 and what effect it has on the the pandemic so far. So with regards to mild and moderate, so I shall deal primarily on mild and moderate cases. Like he's already explained, there is a spectrum of manifestation. On one hand, you have asymptomatic cases, which are people who are just screened and come to be positive, though they don't have any active symptoms. Then we have the mild COVID-19. Basically, these are people who have cough, sore throat, fever, and not much breathlessness, and their saturation and other vitals are all stable. Then we go on to the moderate category where the people usually have, cough, breathlessness. They have some symptoms and signs of lower respiratory tract infection, but thankfully their oxygen levels are well above 94%. And like already stated, these mild and moderate categories usually constitute about 81% of the entire class of cases. And roughly around 14% of the cases are the ones that become severe and require hospital admissions, and the critical cases roughly constitute about 5% of the total pool. Now, with regards to managing mild to moderate cases, we must understand that very early on in the first wave, there was a lot of fear and stigma associated with the disease process, the various management protocols, and a lot of confusion within the physician community itself. And this indirectly led to a lot of admissions into the hospital when it was actually not required because of the fear factor involved. And also quarantining became essentiality, and initially we stuck to hospital quarantine, and then we moved on to institutional quarantine, and then we also moved on to home quarantine. Now it is well established that mild to moderate cases do not necessarily have to come to hospital, and with the boon of teleconsultation, we were able to manage a big chunk of these patients on teleconsultations itself, and we were able to treat them with regular OPD-based medicines as well as various supportive therapies at home. And we had very clear-cut guidelines on when these patients have to even visit the emergency. So now we had though we were not used to such kind of triaging system because ours is not a public healthcare system, very soon, since government aligned and all the other private hospitals also aligned, it became very clear that we must follow guidelines to rather overwhelm the system. We need to have clear-cut guidelines, to manage these patients effectively, as well as reduce the usage of resources. So most of the mild, moderate cases, if you see the category of patients they involved, there were definitive risk factors most of these cases had. One was age, of course, old age, greater than 65 years of age. Then you had either cardiovascular comorbidities, diabetes. You also had other comorbidities like chronic kidney disease, liver disease. They were suffering from cancers and on various immunosuppressive therapies. Now, when you look at mild or moderate cases, the treatment kept evolving right from the first wave up till the third wave. And now we have good experience to state what works and what does not work. Now, with regards to the early phase, most of it is in the infective phase. Once the virus infection sets in, it blows up a cascade of inflammation, and once the inflammation goes beyond control, the patient obviously gets shifted to the ICU, and that becomes a severe as well as the subset of critically ill patients. So as long as they are mild and moderate, we are looking at cases that have only the infective phase, and most of the time are in the infective phase. So our goal is to, one, reduce the attaching of the virus to the respiratory epithelium, and that is where the antibody cocktail comes into play. And since the antibody cocktail is being increasingly accepted worldwide, I think it is a good solution very early on in the disease, within 5 to 7 days of the disease, if people are not vaccinated and have risk factors like they are immunosuppressed or old or have some chronic kidney disease or other chronic ailments which can predispose them to have more severe diseases. And our experience with antibody cocktail also so far has been positive. We didn't have any kind of adverse reactions, and the number of adverse reactions reported worldwide also in data suggests that it is very, very small, and at max it can be an allergic reaction because it is a protein itself. Very early on in the first wave, we had the use of convalescent serum. That theory has been completely debunked, and now we don't use convalescent serum, and it's not proven to be of any benefit anymore. The second drug, of course, which is going to be effective during the viremic phase is, of course, that is going to block, viral multiplication, and they are called antiviral agents. And again, a host of antiviral agents, like you're already aware, favipiravir was there, then now we have molnupiravir. There's another drug in line which is going to be coming very soon. So we have a lot of drugs in line also which are going to tackle mild, moderate very early to reduce the duration of illness. Now in any viral illness, the medicines or antivirals are not going to completely abruptly stop the disease process, rather shorten the duration of illness and thereby reducing the stay of the patient in the hospital and meanwhile reducing the chance of progression into a inflammatory phenomenon. So these drugs definitely, both favipiravir initially was being used extensively in the second wave when the Delta variant was taking over. And in our mild cases, we did see that favipiravir might help, but now there is enough data to suggest that favipiravir might not be as effective in patients with mild and moderate cases. So now we have data coming out on molnupiravir, which is a new drug. And though there are a lot of concerns raised by various bodies in the nation with regards to the complications and adverse effects associated with molnupiravir, our experience seems to be very satisfying, and also we are using it only in patients who require it with a very vigilant monitoring of adverse events, including doing blood tests frequently on these patients. Now, with regards to diagnostics, I think again earlier on the COVID RT-PCR tests and other testing units were swamped because of the fear involved. But now there is because of the absence of any fear, and it is well accepted that the COVID is spreading like wildfire in the community. I think testing itself has been toned down a bit, which is very good. And also only patients who are really sick need to be prioritized the tests before getting them into the hospital. And also the boon of COVID antigen test, self-testing kits which are being made available home helps us to identify these patients early at a lesser cost. And antigen test and as well as symptoms put together can detect a large number of these patients for early initiation of whatever care that has to be done. Now, with regards to certain drugs that were used early on, like ACE inhibitors, ARBs, that were initially pronounced to cause more deterioration, especially in patients who had COVID-19 and blood pressure, there was a lot of fear in using these drugs. Well, now data is sufficient and established that these kind of drugs should not be withdrawn. We need to continue these drugs, and they have no adverse effects on the management of these COVID-19 patients. So in brief, if I have to conclude, mild to moderate cases do form a large chunk of our practice even till today, including the first, second and the third wave. And antivirals and the antibody cocktail stand as the most effective proven treatment in the present world. Will you use remdesivir or dexamethasone in patients with moderate cases is a question quite often asked. Well, there is enough data to suggest that remdesivir should not be used until the patient drops his oxygen below 94, as well as dexamethasone until the patient goes into the severe or critical category. And other, of course, cannot be stressed more. Vaccination definitely has caused more and more mild and moderate cases, which is quite evident in the third wave. And I think vaccination needs to be stressed on. And thankfully, because in India we have a hybrid case of immunity, one of naturally acquired immunity as well as vaccination-induced immunity, it has been a big boon for us in the third wave. We have not seen mortalities or deaths, as well as people suffering from chronic scarring in the lung because of the COVID disease, as well as having a significant impact on various other organ systems because of the vaccine coverage. And most of the cases we are attending to are in the OPD as well as through our teleconsultations. And I think more or less we are getting very good results with such kind of treatment pattern.
Thanks, Dr. Valsa. Now I think the real challenging cases actually. How do you deal with your severe cases? To answer it, Dr. Prakash is the one who is going to answer our questions.
So, Sunil, we were very lucky in Bangalore that when the first wave hit us, it had actually hit Europe first. Italy, then the United Kingdom, and even in India, we had Bombay first, we had Tamil Nadu being affected, we had Hyderabad, before it actually hit us in Bangalore. So we learned a lot of good things as these other countries and other states have experienced, and we knew what might work and what might not work. We certainly knew that putting the patients on their belly, which is proning, was a huge benefit to the patients. We also knew by then that giving them steroids also helped them. We had remdesivir in our armamentarium early on in the disease in our fight against COVID in Bangalore. So the first wave, we had a lot of good information from other countries and other states. The second wave, which predominantly affected a lot of youngsters and a lot of people with comorbidities, which those patients who had other illnesses as well. We went through a very tough phase. We, in Aster CMI, expanded our bed strength from the 25 beds that we had to about 60 beds very quickly. We had to ramp up because there were so many patients. In terms of treatment protocols, not much changed. As Dr. Srivatsa said, in the early phase, an antiviral. If the patient progresses on to have a lot of injury because of the inflammation, we had a drug called tocilizumab that we used. We have other drugs at this moment in time that are as good as tocilizumab. Proline was very helpful. Taking care of their original medical problems, their nutrition and light physiotherapy also helped a lot of these patients. So the second wave, I remember we put a lot of patients very early on a ventilator. A lot of these patients went on to specialized devices like extracorporeal membrane oxygenation. When the lungs couldn't go, we have a machine to deliver oxygen straight to the blood. And a few patients went on to have transplantation as well. But the third wave, which we're seeing now, the third wave has generally been very good to us. The admissions that I have at this moment in time are those patients who come in because of a problem of their primary medical problem. A lot of them come to the hospital and are incidentally detected to have COVID. So in that way, we are dealing with the subset of patients who have very mild COVID at this moment in time. I've only seen 2 patients who have severe lung disease because of the COVID and their primary COVID patients. And the rest of the patients that I've seen are all those patients who come as a problem with a primary medical condition and coincidentally detected to have COVID. And this is good news for us because we have a higher mortality with COVID, and that, as far as we are seeing now, at least in intensive care, the respiratory problems associated with COVID are very small when compared to the previous 2 waves that we had.
Wonderful. So the message is very loud and clear. Now the disease is melodyne when it comes to critical occupancy as compared to first wave, second wave. The third wave is much simpler actually. And the data also justify the thing. The preceding experience, what European, the Western country, what they had actually, that is helping us to prepare ahead actually, so that we can tackle the things in a more comprehensive and effective way. And moving on, I think if you write a chapter or book on COVID actually, probably the vaccination carries a major chunk of these chapters actually, which will be written in a golden letters in terms of the invention of these vaccines. No doubt, I think the preceding experience, what we have with the vaccine is more than 10 to 12 years for the time just to be spent to get one vaccine which is good in its efficacy and at the same time safety. But this unprecedented time where the mortality is sticking at the one, and at the same time the demand is pushing us to push the boundaries, where vaccine was a need of the hour, when we know that these are viral infections, where we have a limited antiviral medication in the pipeline which can help us actually. In that context, I see the viral vaccine actually came up in a boom actually, where in the midst of 2020 and 21, we had a surge of more than 200 different variables actually of vaccines which was tried out actually. With some of the things which are stood the test of time, at least where your mRNA-based vaccines like a Pfizer and also Johnson & Johnson, as compared to a native Indian Bharat Covaxins, and at the same time your Oxford and AstraZeneca Covishield. These are things which has been tested in terms of whether that comes with a sound understanding that vaccine, if not going to cure the thing actually, but decrease the severity of the disease. Now I think probably with the vaccine, the one advantage or disadvantage is as the day progresses, your effectivity of neutralizing antibodies comes down. So there comes a need for revaccinating or a double dose. Now people are already got into a booster dose actually to reinforce the immunity what we have put. The bottom line is that anybody who gets an antibody based on their infection will have better antibodies as compared to somebody with a vaccinated getting an antibody. Because the vaccinated lives are short-lived with not much of a memory B cells or T cells, which will be having a lifelong extensive amount of literature rewarded 60 to 70 to 90% of protection against any of this infection. At the same time, dropping hospitalization rate to by 70%. What else can we expect from the vaccine actually, where 70% where the healthcare system is been strained in terms of shortage of each and every bed and the pharmaceutical agents, 70% reduced with double dose. Now the booster dose. No doubt, if the booster, more than 88% of severe disease can be curtailed. As Dr. Prakash was mentioning about severe cases, if you roll through the list and 62 critical illness which is documented in Karnataka actually, most of them are having an unvaccinated profile actually. Message is loud and clear, the more of vaccination, the better is the sort of a cover in terms of curtailing this sort of severe form of infections. Now, I think moving on to next actually, how different is Omicron from the Delta? No doubt, Omicron known for its variability because of the mutation, the spike protein, which is the attachment with AC of the host cell, AC2 or a TAMP gene, which are the mode of entry into the host cell. These are the two things which have been studied much extensively in the literature as to whether there is any sort of a modality which can tackle this. I think to know the difference between the Delta and Omicron, I'll ask Dr. Srivastava to explain about actually how to differentiate these two things.
So, yeah, thank you. So, I think there is a very important question that has to be addressed. When we are talking about emerging variants of SARS-CoV-2 and variants of concern, when we say variants of concern, what we mean is we are so concerned about whether the new variants are affecting transmissibility, pathogenicity. Second is, are the diagnostics which are already in place, are they going to diagnose these variants? Third is the vaccine still effective against these variants? And is the treatment that we are following so far going to be effective against these variants? Now, with regards to, I'll deal with each of these points one by one very quickly. The first one is transmissibility as well as pathogenicity. So, the Delta variant, which found most of our second wave, we can very well see that it was highly transmissible. It also had increased virulence and pathogenicity and caused a lot of havoc for us, and a lot of mortality as well as morbidity associated with the same. Now, how different is Omicron different from Delta variant? The answer is that Omicron has some changes in its spike protein. So these are crown-like things sticking out of the virus, which helps it to get attached to the respiratory epithelium. Now, Omicron in various studies have already been shown to be having more affinity towards the ACE receptors, which makes it easy to enter into the respiratory epithelium, as well as the incubation period is quite small as compared to the Delta variant. And hence, it has been seen that it multiplies quite at a rapid rate, almost 70 times faster than what Delta would multiply, and thereby causing more pathogenicity in the upper airway as compared to the lower airway. So these are some small minor pathogenetic details of how the viruses are different. Now, transmissibility wise, Delta was almost 2 times more transmissible as compared to its previous variants, that was Alpha, Beta, Gamma, and Omicron is almost 3 times more transmissible than Delta. So definitely it skips from one person to another, and we see it very clearly evident in the third wave that almost every other house has somebody who's already been infected with flu-like illness during the third wave. And during the Delta wave, this was much less common, and hence, the testing paranoia was quite high, and whoever had flu-like symptoms had to rush to see if they really had, COVID infection, or it was flu, or it was something else. And of course, because of the vaccination being not initiated full-blown during the second wave, there was still some apprehensions on people who are still partially protected, whether they will have full immunity against these various variants. Now, of course, there is confounding factors which will also affect on how the cases are seen in the third wave as well as the second wave. The other points are, how Omicron takes a patient to an hospital as compared to the Delta variant. Now, it is very clear that the number of hospitalizations, especially in Omicron variant, as compared to the Delta variant, is 53% less, and the number of ICU admissions is almost 75% less, and the number of deaths, it has been proven in various data or studies, it is 91% less. So you see that Omicron is a less pathogenic variant which causes less amount of damage with regards to morbidity as well as mortality. Now with regards to diagnostics, so see, most of us are using PCR and sometimes antigen-based kits. Antigen-based kits have their own sensitivity and they've always been less sensitive as compared to the RT-PCR. Now considering RT-PCR is the standard and viral cultures not being usually performed, RT-PCR's effectiveness in Delta is slightly less as compared to its previous variants. But with Omicron especially, it was proven that there was something called as a S gene dropout or a N gene dropout. More with the S gene dropout, if you had a spike protein mutation which was covered, so one of these mutations would cause the S gene, which is one of the 3 genes tested in the regular RT-PCR kit, not from being diagnosed, then you have to start thinking whether this is an Omicron variant and then you have to send it for gene sequencing. Now unfortunately, in a country where we have large number of samples, gene sequencing and turnaround times are quite large, and we need to look at these kind of surrogate markers to see whether we are heading to Omicron or. But with regards to management protocols, right from day one of COVID till now, I think though the drugs have evolved, the management principles remain the same. Now with vaccine, I think vaccine prophylaxis without doubt is the most important step to whether the vaccines which are already on board and more than billions of people who have been vaccinated worldwide, are they resistant to Omicron in the same way as they are resistant to Delta was what is in question. Now it has been seen that the mRNA viruses like the biotech or the Pfizer and all those vaccines have been already releasing data telling their vaccines are very effective against the Omicron variant as well. And even Moderna has developed a new vaccine to see whether it is effective against the Omicron variant. Now, with regards to the inactivated vaccines, when we are talking about the Sinovac or the Covaxin and all that, there's still a lot of gray zone knowledge on whether these vaccines completely protect us from the Omicron variant or not. And but inactivated vaccines, as per the rest of the world, does not offer good enough protection to Omicron variant as compared to the Delta variant. Now, with regards to the cocktail, there is enough data which is coming in, and even the FDA has told that maybe the cocktail is not a good drug for patients with Omicron variant. But do we have enough data to suggest this? No, we are still building enough data. So I think we have to wait and watch until we can confirm on this, and maybe there might be a change, a modification in the cocktail antibodies to suit the newer variants. So this is going to be an evolving concept. Yes, this virus is going to keep multiplying. We might have many more variants that come into play. Whether these are variants of concern and whether these variants will cause more havoc is yet to be seen and played out. So we have to just wait and watch. So far I think this is the data available to us about Delta and Omicron. And Omicron is completely replacing Delta in most of the countries, and which is a good sign, and I think, and that is the best way forward.
Wonderful, Dr. Vasa. Now, I think I just asked Dr. Prakash to at least give me some few tips actually if somebody goes to critical care, not to get panic. Now, how the patients can come up, what are the indicators to say that the patient can comfortably sail through this ICU stay without getting into major untoward stuff?
So there is, when patients come into my ICU, as I told you before, the predominant number of them are part of their original medical illness or complications of that. COVID at this moment in time that I've seen, and I'm sure there's a lot of experience around in Bangalore as well, is those are very, very mild variants that we see. The respiratory symptoms, the respiratory illness is not severe. So I would like to reassure, so whatever, when a patient comes to us, there are standard drugs that have been tested and tried, and we know they work. So we will use all those medicines that are needed for. a few, if it is indicated. We have nurses that who are vastly experienced because at least in Aster CMI we've gone through at least 600 intensive care patients over the last two waves. So we have the pool of nurses, I'm sure every hospital has this, we have the pool of healthcare staff who are well versed in dealing with COVID. And we're all from a background where we do general intensive care as well. So we know how to deal with your major medical problems or its complications. So I'd like to reassure you, first thing is, as Dr. Srivatsa said, there is no role for inappropriate drugs, like for example the antibody cocktail is said, but there is still a role for the antibody cocktail in a very, very specific subgroup of patients whose immunity is less either because of the disease process or because of some of the drugs they're taking. The rest of the drugs are fairly standard. We've seen patients recovering within the first few days. We've seen a lot of these patients are being shifted back to the COVID wards in a few days. We've had very, very few of these patients who progress on to the 20, 30 days that we saw in the previous waves. So I think in terms of, please do not be scared about your patient needing intensive care. We do have a lot of experience, and generally we tend to update all patients on a regular basis, so it should be okay. So please don't worry.
Thanks for that assuring words, Dr. Prakash. Now, the thing is, I would just want to bring up on one concept about what is the role of inhaled corticosteroids actually in the treatment of mild cases. This is there in the AIMS guidelines also, which says that actually we always thought that anybody with chronic respiratory disease or the one who have a poor reserve, somebody with asthma or COPD will form a major chunk of comorbid actually, which can trouble the patient. But unfortunately, that was not the case actually. Somebody with asthma, COPD who are already on an inhaled corticosteroid has some beneficial effect. They got to the level where to tease out this receptors where ACE, angiotensin converting enzyme 2, and also TAM plus SS2. These are receptors were down-regulated when you start using inhaled corticosteroid. That was a boon to most of the asthmatic and COPD patients where they were not landing up in any sort of a further disease progression. Means to say that inhaled corticosteroids has a strong role as a form of inhaled corticosteroids in the treatment of asthma, which can be benefited in a mild case to the duration of 7 to 8 days. There are two RCTs which has proved beyond that the beneficial effect of these two inhaled corticosteroids, and also intranasal be not being so effective actually, but inhaled corticosteroids is more so in the cyclosporine and also budesonide and mometasone. These are things which three molecules which has been more efficacious in terms of curtailing this sort of a rapid molecular multiplication. To end up the whole thing, I'll have the last question be answered by Dr. Srivatsa. When to consider the COVID as an endemic disease? This is a golden question actually, which has to be given a due diligence, watching our words actually, how we go to replicate this to the day-to-day care.
So I think that is a $1 million question for any epidemiologist. I think he'll be left confused to say when COVID is going to become endemic, but it is in the near future. So we are aware that, so what is the endemic? Endemic means that a particular infectious agent is constant in a particular geographic area and the rates are constant. It does not mean that COVID should not be feared about. It just means that we have reached a threshold where the deaths will continue at a particular rate in people who are at risk. And we have all measures in place with regards to vaccination and as well as the most effective therapy, which will eventually try to bring down these rates to far lesser rates. And we should not consider, our routine quarantine measures and others which will affect the normal social, economic as well as, the healthcare burden in any particular geographic area or country. Now, with regards to endemicity, we already have major diseases like tuberculosis, malaria, which are already endemic, and they themselves take a lot of lives every year, year on year, and all measures are in place to tackle these kind of diseases on a large scale in the form of national programs as well as various other, hub and spoke models to engage healthcare workers as well as physicians to tackle these, identify these problems early. Now we will have a similar kind of situation with regards to COVID-19 very soon. So that is what we mean. Now with regards to whether the COVID-19 is going to be considered as a common flu, Yes, most of the earlier coronaviruses, like Dr. Sunil earlier mentioned in his talk when he began, most of these coronaviruses also started off in the similar way, and as they mutated, they became less, pathogenic as well as less virulent. Similarly, COVID is also going to die down very gradually, and the amount of illness and morbidity and mortality associated will die down, and also we will only have a handful of patients like this you might identify year on year who will get admitted to the hospital who will require special kind of care. Now, to prevent this is what we need to look at when we are looking at an endemic disease. So, is it going to be vaccination? Yes. And identifying the risk population. Now, as and when we vaccinate the elderly population, obviously the disease is going to migrate into the more susceptible population, which is the younger population. Just like we have our viral agents like influenza as well as other viruses which causes illness, especially in school-going children. It is proposed by various epidemiologists worldwide. Coronavirus might start causing these kind of viral outbreaks in preschools and other things initially, but maybe it will be of less severity, and also gradually because of vaccine coverage even in children, this might eventually die down. Now the million-dollar question is, are we going to be sticking with boosters? Are we going to have every year boosters which is required for the entire population, which is going to be a very big task for any government to hold on for many, many years, isn't it? So, is vaccines going to be like measles, where one vaccine given will give you protection for more than a decade? Or is it going to be like an influenza vaccine where you need to prevent seasonal flu every year? So these questions nobody has the answer to. Vaccines are still undergoing development. Better vaccines will come into play, we never know. And the immunogenicity the vaccine provides us with, or the length of duration, like Dr. Sunil said, the antibodies most vaccines provide us nowadays seem to wane off, and then that is why we have data coming in telling that booster doses might be or precautionary doses required. Now, with newer vaccines and better delivery mode of these vaccines, I think we should be able to prolong the duration of immunity as and when things go by. And eventually, any disease like this is going to become endemic. Is there any endemic disease that has become completely eradicated? If that is a question, yes, there was a disease called smallpox, possibly the only viral endemic disease that has been eradicated like that to that extent. Now, with regards to COVID-19, are we going to reach a state of eradication? Impossible is the word put forward by epidemiologists, and I don't think COVID-19 is going to be eradicated, but it is going to be here to stay as an endemic disease in the long term.
Thanks, Dr. Srivastava. That was a wonderful explanation. Actually, there are positive things. Actually, now future, don't neglect anything. Don't lower the guards. Be on your front foot. Actually, in terms of taking all the precautionary measures. And I thank all the viewers also for logging to watch this particular session. I thank Soumya, Nehan, Virendra. Already the questions have been answered in the last 20-30 minutes of discussion what we had. And at the end, I would like to thank the Aster administration. I'd like to thank the departments who have been involved in the COVID care at Aster CMI, starting from my emergency medicine, internal medicine, infectious disease, the critical care, and the pulmonologist team. And I would be inefficient, incomplete to close this thing without thanking all the nursing staff who just put their life in front of this particular care. At the same time, the group D workers, the nutritionists, physiotherapists, their die-hard thing in terms of taking this good quality care in each and everybody's life where it has been touched in to get them better. And I would like to thank both my esteemed panelists for their wonderful sharing of their experience in this treating of this COVID in the last 2.5 years, which has made us wiser actually. And hope so we'll try to be as sincere and learn from the things which comes up in a day-to-day activity in the future to come. Thank you.